Please, be the chairman, Dr. Matsuo. I'm chairman? Yes, of course. I'm your assistant. No, it's okay. Please, It's always difficult with the live cases because the patient is ready for, I think, for half an hour. Steve, can we go live? Can we? Yeah. Yeah. Okay. Okay, Zolt. Okay, team, can you hear us?
Yeah, we can hear you.
Okay,
so
that's perfect.
Welcome again to the cath lab at the Robert Bosch Hospital. Once again, I want to welcome everybody here. Brian, thanks for making it here. It's a pleasure to doing this case with you. As well in the team, you already know Klaus, who is our constant guy here in the background, and Madita, who's our strap nurse, helping us here today, and everybody else from the team, Joan, doing the registration, and Klaus takes it away with the case, please.
Okay, good morning, or hello everybody once again from the cath lab. We would like to present to you the third case and last case for today. It's a 74-year-old man who was admitted to the hospital with stable angina while doing exercise as a CCS score 3, and he has dyspnea NYHA 2. In the medical history, there is known coronary artery disease, which was treated in 1990 by angioplasty. He has a severe cardiovascular risk profile with hypertension, dyslipidemia, and he is an ex-smoker and has a positive family history. The first findings in the lab were not very conclusive. We have a mild elevated troponin. We have a known left bundle branch block in the ECG, and in the last angiogram we've done, we see a mild calcified right coronary artery, which you can see in the upper left picture. And on the right side, you see the LAD, which is also a very midly calcified, as well as the the RCX. And RD1 is subtotally occluded. So we've done a perfusion stress imaging by MRI, and on the right side we see the stress imaging, which shows us a perfusion defect in the inferior septal area as well as in the anterolateral wall. So today's strategy will be shown by Alex.
Yeah, so a typical case, I guess, where you have a guy with troponin elevation. I think this is a matter of discussion where this comes from, probably from one of the diagonal branches who are severely also influenced by the coronary artery disease. I think today we will focus on the right coronary artery because this is the vessel by perfusion imaging who is putting the most burden of ischemia to the patient. It's a rather calcified vessel with a diffusely diseased coronary artery disease to the periphery. So I guess we will go for an FFR measurement and a pullback to see where the main lesion is. Probably I would guess that the main lesion is within the mid part of the right coronary artery. And then we will decide if we go for an imaging or if we go for direct stenting, if we have, as expected by perfusion imaging, a positive FFR. For this case, we use the OpSens wire. The reason we did that is we are happy enough to have all of the different systems available. And I really like, what I like about the OpSens system, similar to the Boston wire, is that the wire is very good in crossing highly calcified lesions, so it makes it very easy to go down there. Also, we have, that's what the company claims, very little drift, so you can measure and remeasure the problem. So that gives you a very nice impression where to stent, to put in as less stent as possible, but put it in the right spot to reduce ischemia best.
And then the other thing that is not as evident just in this one frame is there's a pretty good right angle turn that you're going to need to get your wire to negotiate, and at least some of the wires out there have better turning capacity than others, and they're not, as a class, they're not in general known for their easy maneuverability. So we'll see how this wire works down the
So perhaps we can go for the actual cath imaging. Can we see the actual imaging? So here you see the image we just took like minutes before. As you can appreciate, the same picture what we saw in the first picture. So highly calcified, very diffusely diseased right coronary artery.
Are you working 5 French or 6 French?
We go for 6 French because if we go for an intervention, in my opinion, it doesn't make too much difference with 5 or 6 French. It just gives you so much more like possibilities. If you, I mean, it's a very, it might be very straightforward, but sometimes you really get into trouble, especially I think in the right coronary artery, because sometimes you're dealing with issues with backup and stuff like that, and it makes it much easier if you go for 6 French. And I don't think that makes so much difference. I don't know how you do it. Did you normally start with, you would go for 5 French here in this case?
Here where you've got a bit of a sharp bend in there, I think there is some question whether you're going to have to put some more muscle in to get it down. If you're using 5 French, you'd probably have to put the catheter, the guide down into the coronary if you got caught around the bend. So there's some good logic to that. Just as the left coronaries are going by, you could see those small, diffusely diseased diagonal that may contribute to part of the ischemia.
True.
But those really look very small, those branches.
So I have a question.
So what does the panel think?
Okay, so I have a question about the LAD. It looks like you have an intermediate lesion right after diagonal, and there it looks to be a little bit tight. I mean, would you assess that? I mean, if you are assessing everything functionally, why not just going and
Yeah, you're totally right. It depends on how much time we will need to go for it. We will definitely do it in this setup. I don't know if we are able to show, since we only have like half an hour to go for, so it might be a little bit tricky to, let's see how far we go, but definitely we will go for and Klaus already showed that, we will definitely do an FFR there as well.
And that lesion in the right corner seems to be also ulcerated in one of the views. So I think it's a very interesting case. The pullback will be interesting also in the right because you have a couple of sequential lesions.
True.
And he's already received 10,000 units of heparin.
So we already put in 10,000 units of heparin just to make sure we can concentrate on the measurement. We already put in the FFR wire. We already equalized, so actually we're ready to go. So if there are no further questions, I would start trying to pull down the wire actually to see what we get.
You already gave the nitro too.
So yeah.
Any other questions from the panel?
No, really a question. I just want to make the point when we are looking at the on the view from the lab on the left and on the angiographic view from on the right. When we go back to the actual live view from the angio, you may notice that the absence wire, the distal tip, compared to the other pressure wires, is a 35 millimeter long. So I understand from the engineers that at the very beginning they wanted to improve the trackability of the pressure wire, but now they do realize that probably a 30 millimeter classical or standard, so the next generation, they will, I assume, shorten the distal tip to 3 centimeter.
And that should probably help any confusion for those that are using different wires to have some consistency in the industry.
But to be honest, I never had a problem with either of the wires. Anyway, you just have to know that you have a different setup there. But actually, that's for me it wasn't that big of a deal.
Small difference.
Yeah.
There is a question in the audience.
Yes, sir? The pressure sensor is always on the same place.
The pressure sensor is at the transducer is at the you know, at the end, the proximal end of the radio opaque part. So it's just really at the junction.
With every company, or no difference between Boston or between?
Sorry.
There is no difference between the companies with Boston or with?
No, we can discuss that. How maybe we can process. So it's an optical transducer.
Mm-hmm.
To make a long story short, I mean, all of these optical transducer are basically produced in Quebec City, believe it or not. I mean, so there is basically 3 companies at this time using optical transducer and optical fiber to transmit. The ASIST, which is a catheter, microcatheter that Dr. Diletti will discuss later on, the Boston Scientific one, and the Opsens one. The ASIST and the Boston are produced in a company which was in fact developed prior Opsens, and it's the same engineers who basically develop all of them. The funny story. Okay.
So then there should be not that much difference. So so if there are no further questions, I will try to pull down the wire actually.
So we've had them equalized already.
Can we see the live angio? Okay, thank you.
See it now? So we'll watch how that tip navigates that hairpin or S-curve. There you go, just jumped across.
So I guess here we have a very nice position actually. We'll confirm it by angio. So I'm quite happy with that. We're just proximal to the.
Can we have a look at the pressure screen now? Okay, thank you.
It is a really.
So it still needs to be flushed with saline. You don't really see a dichrotic notch on the catheter end. There's a little one trying to come back. So he's just optimizing the setup here. Get some flush going in there.
The wire navigated really nice. I'm often frustrated with the current wires we have available on the market in the US. Well, I have 2 technologies, St. Jude and Volcano. And then my fellows also get nervous when they're wiring at the hub, at the TUI, and they end up bending the wires most of the time because the other wires won't bend, and these wires bend irreversibly. And I assume that these newer wires don't bend.
No, and this is my experience as well. So I think it does make differences which wire to take for which lesion if you are lucky enough to have several ones available. So my experience is really we try to plan ahead, and I think that's important for all of the stuff we're doing, to think about what kind of lesion you're expecting, how much calcification. If you want to do IFR, IVUS, and FFR, probably another company might be more suitable doing the job, as we've seen in the case before. Or if it's difficult to get that wire down, then another company might be better. So I guess, in my opinion, it makes difference. That's how we do it. We decide on a case-to-case basis what wire and what system to go to really make sure that we have the best result at the end for the patient.
Yeah, unfortunately, you can't get IFR and FFR on all the wires because of proprietary software.
Apart from the technical difficulties in tracking the wire, drift is one of the major issues, and I think the optical wires perform very well in this respect. Yeah. I think Opsens is probably the best when doing this comparison.
We will see if it holds up if you do the pull back. So I'm keeping my fingers crossed. But my experience is that's one of the big advantages for sure. So we now have a nice steady state at 0.93 at the distal part of it. Should we go for the adenosine? What do you think?
I'd be interested to see what happens when you stress that with adenosine, because it was the MRI was
pretty impressive, right? So
and
we will see.
At least on the surface here, this isn't quite as impressive as I was expecting. I don't know. What does the panel think?
Would you do a contrast shot
adenosine
to document the position of the wire and also to see the contrast
we've already done that, but I can do that actually.
Once a contrast FFR, how's that? Can we give him a good one?
Yeah.
Do you think that the guide may be a little bit deep-seated? I think that there's a mild irregularity where the tip of the guide catheter.
We can pull it back, but actually I didn't see any problems putting in the guide. But we can just.
There's a dichrotic notch. It sort of slipped out of view again.
So it should be better by now.
It doesn't seem to make any difference. I mean, just in case. I mean, those are the check boxes you have to.
No, you're absolutely right.
You have to assure when you're doing these type of things, so to be accurate.
And I think one of the, at least in my experience, one of the most important things also play a little bit with your setup to really make sure before you do the measurement that your guide is in the right position, that you have a very nice equalizing of the wire, and that what you measured makes sense at the end of the day, right?
And then if your guide is sucked in a little bit, that's going to give you falsely normal readings, or may fool you into thinking that the lesion is not significant where it may actually be if you'd had a good guide position. So that's why it's important to play with that.
So I think we go with the adenosine now, please.
Did you give some nitro?
We already did give 2 times nitro, yes.
Yeah, while we're waiting for you guys to come back from break. We had nitro, you guys had coffee.
So you're planning to give adenosine infusion, right?
Yeah,
that's
our standard. It gives us the possibility to do a nice pullback. So that's how we do it here. So.
Okay.
Also, if you want to do a pullback, that's the only option. And in the right coronary artery, giving an IC bolus, a large bolus, sometimes ends up giving AV block, which is not the case with IV adenosine.
And to be honest, a lot of times you're also dealing with osteal problems during. So
you see a drop there. I wonder whether it's being pulled into the coronary.
We can see
there's some beats that are. Because as you drop the pressure, you may increase the flow down the coronary, can pull your guide in.
Just for guiding catheter technique, sometimes by counterclocking the right, the Judkins right, you can just safely disengage while you maintain the wire position. I mean, this is basics, but it's a radial, of course.
So when we use the adenosine IV infusions, we have a time to dislodge the guiding catheter fully, and after obtaining the fully maximum vasodilatation, we put back without inserting too deep, right?
Okay.
So this
well, actually,
so it looks like the pressures are ventricularized.
So I think you had better to dislodge more.
There is
Okay.
some
See, that's
suggestion
more-
just to really put the guiding into the aorta, and because there is obviously some
Okay.
variation in the waveforms.
We can do that.
Yeah, and again, that may be the effect of the adenosine increasing the flow, pulling that guide. Yeah, it looks better in this position, where you still see a dichrotic notch.
Much, much better than FFR-wise and much, much worse.
Look at the FFR now is showing
0.75.
So now you have to decide where is the problem.
True.
0.74. So in net, there's a problem. As the question is where along the way is it? Need to draw another ACT, I think.
Perhaps we first go for the pullback, then we can go for the ACT.
We got everything set up just right. Okay, so now we're getting ready to start to pull back.
So I have a question for you. So I see that in the Sensis system, which is a hemodynamic systems of Siemens, you have FFR and PDPA integrated. Is that something that comes along with the Option system? Because we have the same system in Miami, and I'd love to have just to pull the wire and just seamless integration. So I mean that's a really beautiful setup and adds practicality and the text, nobody rolls the eyes every time you ask for FFR.
So I guess you're doing the pullback now, right?
Exactly.
Correct. We're right into the corkscrew or the Z track right at this point. And that's where you see the gradients disappearing.
So I think it was pretty obvious. I don't know if you guys could see that in the audience, that actually the mid
right at the elbow.
Exactly, right. The mid right coronary artery, as expected, was the one with the biggest drop in the FFR actually.
Do you think we have the resolution to tell whether it's which part of that bend, or does that go through there?
It's hard to tell, to be honest. I
Just
don't
cover it both.
Yeah.
If you are still,
I think what we can do is we can do the first one, redo the FFR and see if it works out or how it goes.
you can either push forward the wire, so the pullback can be reassured by push forward and see the gap again between the two curves.
Want her to turn off the adenosine, or are we still?
Can you also add the mean line to the pressure waveform so you can see a little bit more of the steps up? I mean, that's an easy button to press in the Sensis system. The other thing that I have a question is, in terms of practical interventional strategy, you have that angulated lesion in the mid vessel, but then there's a distal intermediate lesion. So you would stent the more proximal lesion, and then you will see what's the residual FFR after. But then that goes against conventional wisdom, because you always treat from distal to proximal, and then there's always a chance that you get stuck in the more proximal stent, complicating the procedure, or just treat the whole thing with a long stent and just forget about the serial lesions.
Well, actually, to be honest, I don't know how you see it, but I would rather be convinced that the problem is distal to this S-shaped part of the problem. And I think since we have a lot of angulation there, I would try to leave it just there, to be honest, right?
Yeah, just
the upper part, right?
The S part, the Z part.
The Z part, because I mean, I'm a little bit concerned that we get problems in terms of stent deposition and like torturing of the stent, and I think we might just get away with a small stent within the upper part of the S curve. What does the panel think?
Go long or go short?
Can you show again the angiogram?
Can we show the last angiogram, please?
Well, you definitely have to straighten that angulated segment with a stent.
But again, this is a beautiful demonstration of the ease of the tracking of the wire.
Yes, I guess we could see that the wire was really tracking like a workhorse PCI wire. I think that's due to the fact that this is the second generation, so they put an hydrophilic coating compared to the first generation when they had an hydrophobic coating. I think the hydrophilic coating make things quite much easier.
So you're thinking of putting a short stent just to like that second little atrial branch or RV branch that's coming in, and then the distal part, we'll see what happens with that.
We can redo FFR. I mean, in worst case scenario, you are stuck with a 2-stent strategy, but I think it's
But that looks like where there could be the ulcer is where you want to cover.
So I would go for that, actually. I don't know what
sounds like a plan. What does the panel think?
Yeah, okay.
Looks okay. I mean, it seems to be an okay plan. The only thing is that you're going to be stenting from proximal to distal, which is against, just interventional, conventional wisdom. But I think sometimes less is more, and by not touching the distal lesion, the patient may fare the same.
And if we go back to the pullback, I think most of the gradient was caused by the proximal lesion, and as a rule of thumb, a more distal lesion makes much more an effect on the more proximal, and vice versa. So I wouldn't expect too much of a change in terms of the distal lesion, in terms of gradients after stenting the proximal.
And I think, in my opinion, that's the big advantage of the physiological testing in the end, because, I mean, if you say this used to be the standard, how we did that, I think we also have to rethink some of the standard we treated patients, because with these new physiological measurements, now we can really focus on the stenosis, which are most hemodynamically problematic for the patient. And I think that's what all the data shown, putting in less stent but having better outcome at the end of the day. And I think that's crucial, at least for me, I guess.
Yeah, I think it's different when you know you're going to need to go more distally versus right now we don't know and we don't think so. So it's a different risk balance thing. Now, are we going to just direct stent this, or
no?
We're going to balloon it.
I think there might be, or I'm pretty sure there might be a lot of calcification. So I would go for 2.12 millimeter non-compliant balloon to have nice pressure, to have a good idea what size it is. I guess it's a 2.75 stent at the end of the day. I would be comfortable with that, or 3.0, so we can see what size
Get some idea how it looks when the
exactly. So
up.
Can we have a 2.512 non-compliant balloon, please?
With Dr. Berry here, we were thinking about the 3.5, but perhaps we are overly aggressive.
No, 2.5. I'm sorry. So we start with a 2.5 balloon, not 3.5.
The balloon 2.5, but wouldn't you even try a 3.0 and see if it looks small? Just go with the 3.5 stent, because that vessel.
No, sorry, I think there was a misconception. I said 2.75 or 3.0.
Okay.
So this is, I think 2.5 is too big, actually.
And do you think that this is going to be a 3.5 stent?
No, I wouldn't say so. I think I would rather go for a 3.0 stent and then do some pot in the proximal part of the stent. I think it's not a big problem.
Correct.
Going from 0 to 3.
Yeah, so I think especially if you're worried about calcification or the
that's what I've learned from the IVUS, that if you put in too big of a stent, you end up with edge dissections and stuff like that. And with the modern stents, I don't think it's a big problem. Just increasing size.
Yeah, convincing it to grow to the artery.
By the way, you see how much easier it is for a surgeon to treat this patient, because he doesn't need to think about the vessels and the lesions in different vessels. He just puts on one good graft and that cures the whole thing. He doesn't have to think about which lesion is contributing how much, and this is probably why FFR in the surgical field has not gained so much acceptance as yet.
In addition, I don't think that surgeons think.
I do think that they think.
Yeah. And that's a good part, right?
And they don't get to go back. And surgery is always a possibility, even if you do this. So.
But my experience also, if we now have more and more patients treating in heart teams, if you do FFR also in patients who are prone to CABG, actually, it sometimes or it often also changes the perspective, because surgeons normally tend to put a bypass on every diseased vessel at the end of the day, and then you end up with like very good flow in the non-diseased, non-hemodynamically diseased,
and then speeds up the proximal portion.
So I think even if we go for a surgical approach, still hemodynamic measurement makes a big difference, actually. Okay. We have to go for another ACT, actually.
Do you routinely assess ACT in Germany, or is it your practice, or just for the course?
Yeah, it is our practice. Okay. So we have a rather big CTO program. So actually, this is something which is basically now.
So let's do a show of hands in the audience. So how many people routinely check an ACT in the audience? Just a few. And how many just go with the bolus and just whatever it is, you just relay?
Depends on the time.
It's about, the audience here is divided, checking ACT versus not checking ACT. And what if it's infused in the arm? Well, that's why ACT is a safety measure, even when used by bilirubin. So you just check that the ACT went up. We had a couple of cases in which the patient had massive intracoronary thrombosis during the case.
Yeah, with long procedures, definitely that's a good. But routinely for simple PCI procedures, we do not.
So Bernadette was asking what happens when there's extravasation of the heparin into the arm outside of the vein, and that's why the ACT is always a safety reminder in the cath lab.
So the first challenge is to see how well the balloon crosses the lesion.
So is it a non-compliant balloon, or is it just a regular balloon?
It is a non-compliant. It's a 2.5 non-compliant balloon, yes.
NC emerge. Now we're down distal.
So the non-compliant balloons have a worse crossing profile than compliant balloons, just for the audience.
And especially after they've been used. This one hasn't been used. Probably at the lower end of it.
Yeah, true, but I want to make sure, because it was not that easy to cross it. Exactly, I want to make sure that we don't dislocate it.
Do you use cutting balloons or angioscope balloons here in Europe or Germany? Because that's also a nice way. And then if you go with an angioscope balloon, you know that the stent is going to go through, because that's such a stiff and high crossing profile device. And it's nice just to prepare the vessel for nice stenting. But just a thought.
Yeah, it's not heavily calcified, so I think the room and the best indication for scoring balloons or cutting balloons is heavily calcified vessels. And for those who are really crazy about physiology, it's time to reconnect the wire, so to see the coronary wedge pressure during balloon inflation.
What I think?
Yeah. Do you want to hook the wire up, or should we?
For FFR, or?
Yeah, they wanted to watch the physiology as the balloon went up.
Well, this is a physiology course, right, Olivier?
Yeah. No, I've done that. It's very interesting.
As long as you don't use IVUS, we're fine.
Okay. We all set?
We're set.
One up.
Okay.
In my experience, usually this pressure is going to be around 20.
How far up do you want to go?
No, let's just go to 12, actually. You can go even higher because it's in non-compliant. Just go for 16, I guess, and we crack the...
All right, we're at 16.
16.
So this is exactly what Grunzig showed in his first angioplasty.
And I think, as you can appreciate here, we have a very nice opposition of the balloon, so I guess was very nice in terms of times. I think we're okay. Just wait. I will I will use that to put in the guide a little further. Okay.
Ready to go down?
Down. Okay.
So that waveform would predict no collaterals then?
Let's have a look.
Do you have any problems reconnecting the wire to the transducer with OpSense?
Not at all.
Sometimes we do. And
this is also, yeah, this is also some of the big advantages. Actually, this is the FFR system our fellows normally start with, because you can be very, very messy in terms of blood and whatever. Still works pretty fine. So it's not a very, it's a very robust system where you can just go for anything. So.
And that's the advantage of
You've
optical
already
technology.
done a nice job.
By the way.
The funny
And
thing
if you look,
the funny
so
thing
if
is
you
that
now look at the FFR, we are now at 0.95, so already improved the gradient.
It's a Beneston patient.
And that's also a good argument for leaving the distal lesion alone.
So
Change contrast.
okay, we go for heparin. ACT was 163.
Pretty nice result just from the balloon.
So by using this pressure information during procedure, we can get many kind of information.
Yeah.
For example, FFR collateral is 0.28, relatively high.
It's pretty high up.
Right,
Yeah.
very high. So probably it's a symptom, and electrocardiography doesn't change at all. Is that right?
yeah. Did you, we
this
were
a left
mentioning
bundle
that
it is a left bundle.
the distal pressure was quite high, so we were assuming that the patient did not feel any chest pain and there was no ECG changes during the balloon inflation because of the
They
good
have left
collateral.
Well,
bundle
he
like
has-
block, so it's difficult.
It's an interesting case.
Left bundle
And
bench block.
another information
Oh,
is after ballooning, we can induce the reactive hyperemia by the balloon hyperemias,
Yeah.
right?
No.
Yeah.
So we can get the FFR value very, very easily,
Yeah.
right?
That's
So
true.
just putting the balloon to the guiding catheter and to make sure the guiding is not waste. Probably the balloon, 30 seconds balloon inflation
I think, yeah.
causes
330
seconds
non-compliant
hyperemic
also,
duration.
right?
Yeah.
So probably we can get
Well, that's the stent itself.
Good result with
well,
You would
good
go for the
result,
stent, Eric?
right?
At this point,
Yeah, we can go, right?
yeah, we already ballooned it, so yeah, I would just stent it.
3 point, kann ich einen 3016er bitte haben? Synergy? So we were just discussing about what kind of stent to go for. I would go for the 3.016, or we can go shorter. We can.
Yeah, I think
3.12.
you could go. There is a little bit of disease more proximally.
Exactly. I would
sort
just
of
cover
rest-
that as
Yeah.
well, and it makes it a little bit easier to
And
find the right spot.
Trying
also.
to position a little tiny short one
Exactly.
is a challenge.
And-
I think
and-
you can
and also
concentrate on the where the distal tip is and let wherever lay there. And you can always post dilate up in there if you think it needs to be expanded.
Yeah, true.
Just for the sake of this
Yeah,
teaching
I think-
course, would you be measuring FFR now after ballooning before stenting to show
Actually,
how much of the
we-
hemodynamic consequence of this lesion has been taken care of? I think most.
We
So
can
probably
do
have a
that
high
actually. We can do that.
FFR.
But basically, that was what was mentioning by Dr. Matsuo. When you use the balloon,
Yeah, that's
with
hyperemia.
and
Absolutely,
pressure. So
absolutely,
basically, you
Um,
know
exactly.
Joan,
kind
That's
of
true.
Wenn wir
That's true.
Adenosine-
And I would like
immediately
to,
after.
to duplicate this in order
Yeah.
to see
Yeah,
that
let's
the
do- let's
hyperemia
do-
caused by balloon inflation
let's-
is already
Yeah,
almost
let-
maximal.
let's do the measurement actually.
But Ian, I think I would go with the longer stent. I think that there's disease from the post-stenotic dilatation all the way back to that small branch that then goes up. So that would be like a 26, around 26, 28 millimeter stent, maybe. Sometimes when you take a picture with the balloon inside, you can actually assess. You already have a 12 millimeter balloon there that looks
It's
short to
a
me.
35 millimeter wire tip there. It's
so actually we had a 2.5 12 millimeter balloon, and it covered quite nicely also the upper part. I think we can get away with
that.
This
Was a 12 millimeter length.
So I think
balloon.
we can get away with the 16. What do you think? Or
that's what I was thinking.
Yeah.
The rule of thumb, you never listen to the panel. You go with your heart. Otherwise, you get like TCT. You get in crazy situation.
Well, and if we're wrong, and I mean, then you have all the benefits, and we can say that you were right. So
more talking points.
More talking points. All right, we already started with the adenosine. I mean, that's the only downside to doing it systemically. It takes just longer to do so because but in the end, I guess there's not much difference. There's pros and cons to everything.
Yeah, we used to use a lot of nitroprusside back when the nitroprusside cost in the U.S. was $1 per vial. Now it's like $700 or $800 a vial, so that went out the window.
I'm really sorry about this suggestion. I was asking for a quick and dirty bolus.
No, that's fine. I mean,
you can stop. I mean, you could potentially stop here and
I think it's fine
and conclude the case.
I think we're fine.
Yeah, it's 0.9.
0.9 is fine. So I guess
that's a beautiful angioplasty result.
And now we're going to make it into a beautiful stent result.
Yep.
Stent-like.
Don't jinx it.
No, it will be a stented result. Here it comes. It's stent-like right now, but it's going to be stented.
I got it.
This is all rapid exchange equipment. So that seems to slide in easier than the balloon did.
Your balloon did a fantastic job there, for sure.
Thank you.
Yeah.
So now we're concentrating on the distal tip to make sure that it's where we want it. And then we're going to allow the back end to go where it lays. So it looks like it's in a little far now.
What do you think?
It's pretty close.
Think a little bit, or what do you think?
I think it's in a good position myself.
I think we would go. Okay, go for it. Yeah.
You're going up?
Yeah. I would go for 14 or something.
I think so. It was claiming to take 26.
There's 14. A little bit of air down the tip.
Perhaps 16 with a little tip, I guess. There. Yeah, better.
So what's your pressure?
16.
16.
16.
Come down. 16 and down.
I had the impression that we had a little bit of recoil or a little bit of opposition in the mid part of the vessel, which resolved very nicely now. So let's see what we got actually. Nitro, please.
So I think the length looked like it reached back. We'll see.
O2.
So is that 100 or 200 mics? Nitro?
0.2 microgram.
Should we hook up the wire?
I think we should just go first for the angiographic result. And I'm very happy with that, actually. What do you think?
Looks good. It's, you know, right at the bend, we were expecting to have a little dent in it, which is what it's got. I think if the physiology still looks good.
We're good, right? What does the panel think?
Kind of quiet. You guys getting tired?
So we had a discussion about the length, and when I would say the stent was being deployed, I mean, we get the feeling that maybe 2 millimeter more would have been perfect, but at the end of the day, physiology will decide.
2 millimeters more going distal or 2 millimeters more back proximal?
Distal.
Because I think we were trying to stay out of that distal bend.
Okay.
Since the physiology didn't seem to pick up much in that region.
So back on the FFR track, can we start adenosine, please?
So now this wire has been plugged and unplugged several times, and so far it seems to be holding true.
So just have a simple question. Do you use the optomonitor, or is it the curves are coming from your cathlab system?
This is from our cathlab system, actually.
Oh, nice. Okay.
So that one's their monitor, the
exactly.
small one on the side.
We have perhaps you can see it. We have another small monitor, but this one works very fine for us, and it's the one we use for every FFR, so it's very consistent, and I would like it to be as easy as possible, actually, if you're dealing with physiological measurements.
Nice.
So you have the adenosine running in, correct?
Yep.
The drum's rolling. PVCs. So when we were done with the balloon, we had a 0.9 or 0.89.
I think an FFR pullback here will help you qualify where the remaining gradient lies, albeit it's acceptable. Absolutely.
We can go for a pullback. So I go
just for the teaching course.
I go for a pullback.
So we're coming back now.
So here we already with 0.93. So we are distal to the stent, and we have like 0.9496. Now we're back to the guide, actually.
Okay.
So you don't see much in the way of drift here.
No.
So thank you very much. We're going to try to keep up with the pace of the final lectures, but it was a wonderful case, and it's a very nice introduction for the post-PCI FFR assessment, which is the topic of the next session. Thank you very much.
Thank you very much. Thank you. Thank you.
So maybe we're going to try to accelerate a bit. I'm going to try to do my talk in 5 minutes. It's more like an introduction to the next speakers.
The next session. I don't need to introduce the panel. We've all been panel members before. So it's my great pleasure to introduce Olivier, whose work around post-stenting FFR has really increased the acknowledgement of this important indices in the field. So Olivier, if you could start.
Okay, so thank you, Mama. So I really want to set up the stage for the next topic. I've become interested in this post-PCI FFR, which is not, as you know, recognized in any guidelines or any indication, but I'm going to go through a few observations, and I think it's going to be a nice topic which is going to be discussed in more detail by the next speakers. So how do I move this? Okay, so my disclosure, I will just go. So obviously I've been working with Opsans for quite a number of years, and as you know, I've been committed with the transradial world and now the physiology. So I'm just going to show you an example. I mean, this was a patient which was 83 years of age that we did with the first generation of the hydrophobic optowire. And as you can see, there is a moderate lesion on the LAD. So it's quite an old patient who presented with unstable angina de novo with rapidly progressive symptoms. As you see, there is basically tandem lesion on the mid part, and there was also some lesion on the diagonal. For the sake of the discussion, I will focus just on the LAD. So you're going to see that we did the okay. Let's look at the lateral view. As you see, the first lesion we see is very tight, and second one is moderate. So we did the FFR before, very severe, as you see, 0.47, so it's clear-cut indication. And then for the sake again of this presentation, I use a small balloon first, a 2.0 millimeter balloon to pre-dilate, and then I repeat so you see it's obviously suboptimal result. Just the FFR now is 72. So you see there is an impact on the balloon dilatation, but still below the ischemic threshold. So the next one, I go with a 3.0 millimeter balloon, and I repeat the FFR, and it's 82. So obviously now in nowadays practice, I put a stent, quite a long stent, try to cover both lesions. And I will repeat. So you see, angiographically, I guess you will assess with me that in my view, at least, I mean, there is a slight overexpansion. There is a step up, step down, like we used to say in the old days. And so I would say again that angiographically is a perfect result. I'm going to show you the lateral view. As you see, the clear-cut zone where the stent is covering both initial lesion, and then when you proceed with the FFR, you got 84. So because he was obviously quite an old patient, the angiographic result was perfect, we stopped. And then at the time, we were interested to look at the literature, and this is a paper done with one of my PhD students. Basically we reviewed everything prior the emergence of the new fiber optic pressure wires, and this is covering something like 20 years of FFR measurements after PCI, including for the red dots after PTCA. And you see there is some variation over the years. As you see also, there is no more recently improvement or increase in the post-PCI FFR values. So that's observation number one. Observation number two is that when you look at the mean value which has been reported in this study level meta-analysis, the classical value, the median value is 0.90. There is some plus 0.04, and as you see, when I try to emphasize with the two arrows that 85% of the lesions are comprised between 85 and 95. So these are really the data from the literature stopped about 2 years before. And is there a relationship with the outcome? So we looked at the rate of repeat PCI, so repeat intervention, which is obviously related to the target vessel. And you see again, I would say that the better the higher the FFR, the better the result. And numerically speaking, when you got a value above or equal to 0.90, well, I mean, you get more than 50%, more than 60% relative reduction in the risk of repeat intervention on the vessel. And even more interesting, when you look at these, the MACE incidence, again, you see that you have like a 30% relative reduction, which in my mind is quite interesting because this is obviously one of the limitations, as you know, of meta-analysis. It's a mixed bag of studies, mixed bag of definition, mixed bag of methodology which is impossible to catch up in this kind of meta-analysis, but it seems to have a signal in terms of risk of repeat MACE and repeat intervention on the intervened vessel. And this has been also analyzed by a study which was meta-analysis with individual patient data from Niels Johnson. And you see he divided the measurements after PCI according to the value, so there is tertiles. And you see basically that again the higher value immediately after PCI are correlated with better outcomes at 2 years. 3 years in this study. So to me there is a signal, and I think that with the new introduction of the fiber optic wire, I mean, this is a unique situation which may introduce some new indication for post-PCI assessment. One thing though that we should keep in mind is the influence of the diffuseness of the disease compared to the focal. And when you look on the left side, obviously if you have a focal lesion and you have an FFR value which is, like positive prior, of course, if you put a stent, you may anticipate that the value afterwards will be close to 1. But in today's practice, when we get more diffuse disease, more, let's say, tandem lesions, I mean, you may guess that the value immediately after, which probably will remain basically less than 0.90. And in my experience, I mean, we discussed this morning about the location, and the more cases I do by using post-PCI FFR assessment, and that's something we're going to learn from the other speakers, is that, for example, it's almost impossible to get the so-called 0.90 after LAD intervention. So I just want to go very quickly about how bad as a intervention as we remain, and these are data from the ABSORB2 when they compare, as you know, the now defunct BVS and the Xience. And when you look, I hope you can see the arrow, but after one year and 6 months, you see almost that 20 or 25% still remain with angina or with a positive exercise test. And obviously those studies comparing to, let's say, state-of-the-art devices means that by just looking at the angiogram afterwards, maybe we are not so good to predict what we have been doing for stable patient, which is relief of symptoms. So this is the same thing in terms of objective evidence of ischemia, but it basically says the same. So I'm just going to show you the connectivity as that we couldn't see, but you see there are two things. Okay, there are two ways. First of all, you see the green line, but because it's fiber optic, so it's a transmission of the light. So with this fiber optic connection, in fact, you get also the sound. So you get an immediate signal that you are reconnected, and you don't get the pressure drift because of the fiber optic transmission. So as a summary, I would say that optical fiber technology allowed us to develop improved PCI like floppy wire, so we can go to more distal and more complex lesion with a much improved connectivity, and the physiology assessment, which is now well established prior intervention. Maybe it's the right timing to think that we could also perhaps integrate the post-PCI assessment in our clinical judgment. Thank you.
So do we have any question time, Olivier, or?
Maybe we keep the question for the end of the session.
Okay. So if we ask the next speaker, Dr. Piroff, to come and talk about post-PCI FFR lessons from FAME on the back of a recent publication in Circ Interventions, I believe.
Yes, thank you very much. Can I have the slides up? So, ladies and gentlemen, it is my pleasure to present the data from the FAME-1 and FAME-2 studies concerning post-PCI FFR measurements. And by the way, in the meantime, can we have a show of hands how many of you actually do measure post-PCI FFR on a regular basis? So it's still a minority. Let's hope that next year when we have the same session somewhere here, more people will show up. Anyways, so I would like to give credit to my co-investigators, especially Gabor Tóth and Bernard de Bruijn, for this publication, which we had a couple of weeks ago in Circulation Cardiovascular Interventions. So, as we all know, FFR has a 1A indication to identify hemodynamically significant lesions when evidence of ischemia is not available, according to the latest European Society of Cardiology guidelines. Actually, it was in 2010 that it was given a Class 1A indication. Many of us thought of FFR as a dichotomous variable, whether or not it's positive or negative, whether or not we should embark on a PCR or not. But actually, it's not just a yes or no tool, it's a quantitative tool, because it has been shown by a beautiful paper by Emmanuel Barbato and Bernard de Bruijn in that in medically treated patients, outcome data indicate the risk continuum for FFR values, with lower values having higher event rates. So the question why our well-desired post-PCI FFR value is not always one is basically there are four explanations, and I think by far the most important one is diffuse coronary artery disease, which we see more and more. And I think this is one of the explanations why we have less and less perfect values nowadays as compared with the old days. Of course, you may have circumscribed other unnoticed or neglected lesions in the index vessel, which do turn out to be hemodynamically significant or impacting on post-PCI FFR. Suboptimal stent placement is a potential mechanism for low post-PCI FFR, but with the advent of high-pressure ballooning, this is not really a good argument, because FFR, to be honest, is very insensitive to detect suboptimal stent placement, and intravascular imaging is much better at that. So even if you arrive at a very good high post-PCI FFR value, you may have underexpansion as shown by OCT or IVUS for that matter. And the fourth one, which is easy to see on if you look for that, but sometimes you forget, is drift. So the objective of this present study was to investigate the potential of FFR measured immediately after drug-eluting stent implantation to predict clinical outcome. And for that we used all patients from the FAME-1 and FAME-2 studies who had post-PCI FFR measurements. Of note, both studies suggested but neither mandated the measurement of post-PCI FFR. This is why not 100% of these two studies were included in the present analysis. We did a vessel level analysis on the relationship between post-PCI FFR and outcome, and the endpoint, the primary endpoint, was vessel-oriented cardiac event rate at 2 years, defined as a composite of vessel-related cardiovascular death, vessel-related spontaneous myocardial infarctions, and ischemia-driven target vessel revascularizations. We have to remember that both studies involved clinical event committees who were not only unaware of the patient allocation to the different arms, but also to the post-PCI FFR values. And all the events were adjudicated by these committees, so it's a very robust data set. We counted all deaths which were not clearly attributable to a non-cardiovascular cause, and we did not count procedural infarctions, just spontaneous late myocardial infarctions, and both urgent and non-urgent target vascular revascularizations were counted. This is to show the patients. In all, we had 644 patients in this study. Actually, it accounted for 2/3 of the total population of FAME-1 and FAME-2. And you can see the different baseline characteristics, with 79% being male, 68% having hypertension, 3/4 having dyslipidemia, and 1/4 having diabetes. There was not much difference between patients coming from the FAME-1 and the FAME-2 studies, with only hypertension being statistically significantly more frequent among patients coming from the FAME-1 study. And there were some differences in terms of angina severity as classified by the CCS classification, but this is not really clinically important. In these 644 patients, 850 vessels were measured. If 50% of these were LADs, a quarter were circumflex, and a quarter were right coronary arteries. There were some differences in terms of baseline diameter stenosis from the FAME1 and FAME2 cohorts. And serial stenoses were more frequent among patients coming from the FAME1, and also the baseline FFR was somewhat lower in the FAME1 cohort, 0.61. But importantly, the number of stents, and most importantly, the post-PC FFR value attained on average was the same, being 0.90 in all studies. This is to show the distribution of these 850 post-PC FFR values measured. We grouped them in tertiles, with the lowest tertile having a post-PC FFR of 0.88 or less. Less than 0.88, the highest tertile having a post-PC FFR of anything above 0.92, and the middle tertile being in between, shown in yellow, and the first is in red, and the best tertile in green. By multiple regression analysis, we could define some predictors, some clinical predictors of low or higher post-PC FFR. As expected, male gender, diabetes, LAD location, and multiple stents in the index vessel were predictors, significant and independent predictors of lower post-PC FFR. It's quite easy for us to understand that male gender and LAD location, probably by a larger subtended myocardial mass, account for lower post-PC FFR values, whereas diabetes and multiple stents in the index vessel probably cause lower post-PC FFR because of the more diffuse disease. On the other hand, a higher baseline percentage diameter stenosis and higher baseline FFR predicted a higher post-PC FFR value. When shown these post-PC FFR values in strata of 0.05 and comparing it to the rate of VOCA, which is the vessel-oriented cardiac event rate at 2 years, you can clearly see that the highest stratum has the lowest event rate, with barely above 3% in 2 years, whereas anything below 0.80 carried a risk of this primary event rate of at least 8%. But we grouped the event rates in the tertiles, and this is to show the primary endpoint of the study. Those with post-PC FFR value of above 0.92 had a statistically significantly lower risk of having vessel-oriented cardiac event rate at 2 years, with the hazard ratio of 1.46. This was statistically significant between the lowest and the highest tertiles. The middle tertile came in between. This difference was not driven by difference in death, which was low in all tertiles and not statistically significantly different, or myocardial infarctions, which were again infrequent and not statistically significantly different among the three tertiles, but it was solely driven by target vascular revascularizations, being statistically much more frequent among those with a low tertile, with the lowest tertile less than 0.88, as compared with those in the highest tertile, anything above 0.92, and again the middle tertile came in between. By a sensitivity and specificity analysis, we were trying to establish the best cutoff value to predict a vessel-oriented cardiac event at 2 years, and that turned out to be 0.92 in this analysis. But even at this best cutoff value, the sensitivity was 75 and the specificity was 43%, leaving us with a positive likelihood ratio of 1.31 and a negative likelihood ratio of 0.58. So in conclusion, ladies and gentlemen, in this analysis we clearly showed that vessels with lower post-PC FFR immediately after drug-eluting stent implantation were associated with more events than vessels with higher post-PC FFR values, and as shown here, the best cutoff value was 0.92. This difference remained significant even after adjustment for various clinical, angiographic, and procedural characteristics not shown here. So conclusion number one is that this residual FFR burden further extends the overall prognostic value of FFR to post-PC FFR measurements at a population level. However, the sensitivity being 75 and specificity being 43%, and the low likelihood ratios to predict further events were low, and therefore we think, based on this data set, that post-PC FFR cannot be proposed as a surrogate for clinical endpoints or as a target value to optimize PCR results. It is too weak to rule in or to rule out future events in individual patients. Thank you very much.
I have a question. So, I mean, this is a very nicely done study, and I think illustrates the limitations of post-PCI FFR. What I see, even though you did the adjustments for clinical and angiographic factors, you can only adjust for things you know. So my question here is whether or not this lower post-PCI FFR is a surrogate for more diffuse and aggressive atherosclerosis in the patients that had further events, instead of just being something you can technically correct.
Absolutely.
Or your lousy stenting technique.
Yeah, you're right, absolutely right. And this is why I listed the 4 possible mechanisms. Not even drift was taken in the CRF, so we were not mandated to pull the wire back and see what the post-PCI or the FFR at the tip of the guiding catheter was. So if we had some data on drift, probably the sensitivity and specificity would have been better, but that's a guess. Of course, we more and more see diffuse disease patients, so I think that this is by far the most important reason why we do not have a post-PCFFR value of 1.
So if you had to recommend an individual operator what to do you think you have to measure, or you don't just don't care about that and just don't waste your time and get your next patient?
You know, when I started doing this analysis, I think I was hoping for something as clear as pre-PCI FFR values, arriving at 0.90 as a good cutoff with high sensitivity and specificity. This is something we did not have on the individual basis. Still, this is in line with all the previous data that we had, and also the meta-analysis that Olivier was alluding to. The higher the better. That's true on a population level. But what this is saying to me is that if you arrive at a post-PCFFR value of 0.85, and this is not technical because there is no drift that you have checked for, there is no proof to say that you must be aggressive and go on and put any number of stents, go higher with balloon inflations and so forth in order to arrive at a higher post-PCFFR value in the hope that the patient will have a better outcome in terms of hard endpoints. So this is what it tells me.
Olivier?
So my comments will not be politically correct, but I guess you will agree with me. You know, we have to remember, and that's something we have been trying to go beyond with this kind of course, that you work under the umbrella of Nico Pales and Bernard De Bruyne, and I have discussed many times with them, and I believe quite fascinating that those guys, let's call them the guru of the FFR, they spend 20 years and more of their life to tell us that when you have a lesion prior an intervention, you include the diffuseness of the disease anyway, you have the lesion, and finally they came out with, first of all, an ischemic threshold of 0.75 that moved by guidelines to 80 without any more objective evidence. And now they are just telling us that anyway, there is no chance that we can define an ischemic threshold after, when at least we have modified the disease by the segmental therapy or something. So I just believe that it's an overstatement. They simply do not believe it. They are stuck, I do apologize, they are stuck in the past, and I think there are many things that we're going to learn. Those studies will include patients like more than 10 years ago, only stable patient, completely different disease, and I do believe that you will continue to do post-PCI FFR. What I would like to have your final comment is that this threshold of 0.90, the more cases we do today, I think is like the holy grail. I mean, we cannot get to the 0.90, especially in the LAD. So we don't know, like Dr. Matsuo, which is also doing a lot of post-PCI, and using now the ischemic threshold of 0.80 to stop. Or should we at least optimize and perhaps put one more stent? We simply do not know at this time. That's my view.
Exactly, I completely agree, and I think this data set supports what you said. And I think the reason why this is so is because the whole picture has become even more complex. Because of course, before PCI, we have the natural disease. We know the natural history. We can modify that little by medications, by diet, and so forth. But this is something that we know. Now we intervene. We placed in a metallic structure in a specific segment and did vessel trauma and everything. Now the whole thing becomes even more complicated. And I think this is why we will never arrive at a specific number, that we must achieve this in order to have a better result in that particular patient. Of course, population-wise, we know that the higher is better, but even by higher, I mean, of course, less diffuse disease. So this is why I think that post-PCI FFR cannot be as helpful as pre-PCI FFR in order to what you have to do in the cath lab with your own hands. This is what it says to me, that it's a little more complex picture, and this is more difficult. There are many more things to be taken into account. And an LAD is more different. Of course, we know that having a post-PCI FFR about anything above 0.90 is less than 40% of the cases.
Yeah.
Before the PCI, say 0.58, and you did the job, and post-PCI it's 0.77, and you see that you cannot do anything. So do you still believe that the patient is still in the ischemic threshold?
I think so. I do think so, that the patient is still maybe ischemic then. What I know is that I have helped that much from 0.65 or 56 to 77, and it's the bad surprise that we sometimes have, that we think that we did a good job and still we still have a not perfect FFR. The reason why I always use post-PC FFR, if it's technically feasible, is because sometimes I find something that I can treat. That really, if in this case, maybe a neglected mid-LAD lesion, which looked intermediate, is causing this kind of pressure loss. And this is why I could stand it and arrive at a non-ischemic. So I'm always aiming at least above 0.80. But I don't think that based on this data set, we have proof to say that above 0.80, you must go on and do something. Because, of course, it means more stents, more trauma to the vessel. So there is something else being done to the patient. And this is why I think we have to go on. And a randomized trial is needed, because this is not a randomized trial. A randomized trial is needed for LADs with a post-PCFR value of 0.85, whether or not the patient should be stented on or just left alone on best medical therapy.
Okay, thank you. So we're going to move on with the program now. So thank you for that talk. And the next speaker is Roberto Diletti, who's going to present the Rotterdam experience of post-PCI FFR.
Thank you for the introduction, and I'm very happy to be here for the second time. I'm going to talk about the post-PCI FFR experience in Rotterdam, so I'm very happy to talk on behalf of my colleagues in Rotterdam. The need to investigate the post-PCI FFR came to our center with the idea that probably we can shift a little bit from what is the current use of fractional flow reserve as an index to have an indication to treat patient towards something that is giving us an evaluation of our procedure and the results of our procedure, and probably also shifting from a binary value to continuous values. So what we did basically was a prospective all-comer registry, and all patients who underwent a successful PCI were practically eligible for this prospective registry. The FFR was performed at the end of the procedure. So when the operator was sure that the angiographic result was acceptable and that was the final result, then was performed the FFR. The FFR was performed also with a novel device that is the Navus microcatheter. Is basically a device that is allowing us to maintain wire access to the vessel. So this is the device basically. It's a device that can be used with any coronary wire, and it has a marker located at 2.5 millimeter proximally to the distal tip of the microcatheter, and 2.5 millimeter even proximally. You will find the fiber optic sensor of the device that is giving us the assessment of the FFR. One thing that is very interesting is the fact that the profile of this device is 0.022 inches. That is more or less what is given by 2 coronary wires in the vessel. So our first idea was, are we giving an extra impairment to the flow in the coronary with this device? Well, an interesting study on this topic was given by Matthew Price and his group, and here you can see the correlation between the two methodology. Basically, what it was seen in this study was an average bias between the two techniques that was 0.02, and this bias was more evident when the FFR value was very low, especially in the microcatheter, and probably we can discuss later why this is happening. So what we performed was what we call the FFR Search Study. So our registry, including initially more than 1,500 patients, and precisely 1,000 Navus catheter were used in those patients. As you can see here, in the end, 959 patients had at least one lesion assessed after PCI, and this is giving us more than 1,100 lesions assessed with post-PCI FFR. Here you can see the baseline characteristic of this population. Nothing special, it's just reflecting our everyday life. But what I think is important to notice here is that also acute coronary syndromes, unstable angina, non-STEMI, and also STEMI patients are included in this database. And this will give us in future the opportunity to have sub-analysis in these subgroups. So here we can see the FFR procedural data of this patient. As you can see, the PDPA at the end of the procedure was 0.96 as an average. But also what is interesting is the fact that the drift value was quite limited using this microcatheter, and similar probably to what we have with FFR wires. Also, another interesting point, I think, is the time to perform the entire, this is the global time to perform the entire FFR from when the package is open to when the microcatheter is out of the patient. And this is due to the fact that it's a rapid exchange device, so it's very quickly performed. In some cases, it was not possible to cross the lesion, 3.5% of the cases, and also there was no complication related to the use of this technology. Here we can see the lesion level analysis of FFR data in this registry. What is interesting, I think, is that 43% of the lesion were below the 0.9 threshold that we have just discussed. But it's also interesting to see that 7.7% of those lesions has also an FFR that was below the threshold for ischemia. And here you see the patient level analysis. It's basically reflecting those data on a lesion level. And we can see that nearly 9% of the patient has at least one lesion that is below the threshold for ischemia. This data set was recently completed, so we have just 30 days clinical outcomes that are not really meaningful. We can just see that the MACE rate is low, but this is normal at 30 days, and we should consider that this registry is meant to have a follow-up up to 5 years. And here you see the MACE rate at 30 days. The p-value that you see there is the comparison between the two extremes, FFR less than 0.8 and FFR more than 90. Of course, is non-significant, but is 30 days MACE follow-up, and is not meant to be significant, of course. The only thing that we have seen regarding the event rate is that they are going anyhow in the direction that we expect. So higher event rate in low FFR cases and lower event rate in higher FFR post-PCI cases. But again, this is just 30 days follow-up. So what we can think about if we look at this data? Well, first of all, that we're performing a post-stenting FFR was safe, no complication, and it was quick to perform. Another important thing that we can understand is that a relevant percentage of our patients at the end of the procedure, they have an FFR value that is less than 0.9 that we have just discussed. Also, what we need to understand now, the next step, is if optimization of the PCI after these FFR values is important to improve clinical outcomes. And for this reason, we are going to start now a randomized trial that is the FFR React, that is basically using IVUS-guided optimization in patients with a suboptimal FFR. So basically, patients will be randomized to IVUS-guided optimization or nothing if they have an FFR post-PCI less than 90. Thank you.
So thank you for an excellent talk. Are there any questions in the audience? No.
So purely theoretically, what do you think would drive a supposedly higher MACE rate in patients with an FFR of, say, between 0.80 and 0.85 versus patients with an FFR of 0.90 versus 0.95? What would be the mechanism of that increased MACE that you expect?
It's a good question. It's a very good question. I think it's the ischemic burden that we could have in those patients. What we have seen in all the data previously published, also on the FAME trial, is that the FFR post-stenting could be considered not as a, as we said before, not as a binary value, but as a continuous values reflecting the atherosclerotic burden that we live in the coronary. So yeah, we are doing this study just to understand what will be the mechanism, and we are using IVUS also to understand what it will be the mechanism of low FFR after stenting, because we have also a sub-study, an IVUS sub-study of this registry, where we see basically the different scenarios that we have, and we have proximal lesion, focal lesion, in-stent under expansion, and distal focal lesion or diffusely diseased vessel. These are the different scenarios that we can have. And these different scenarios has a different possible approach from us for correction. So yeah, I think we will try to understand a little bit more also with the imaging what could be the mechanism.
Olivier?
Yes, it will be presented at TCT. Yeah, and yes. Yeah, well, I must say that there is also a high rate of diffuse disease, distally to the stenting usually. And yeah, that is the different scenarios that we can have.
Okay, great. Well, thank you for the talk. So moving on, the last speaker, I'll struggle to pronounce the name, but I'll try anyway. Gidrius Davidasius, who's going to talk about post-PCR, FFR, and long DES. So I apologize if I've massacred your name, but anyway.
Yeah. Thank you very much for the possibility to be here. Thank you very much for an invitation. And the topic I'm going to present today is post-PCI FFR after long drug-eluting stent implantation. So this slide was already shown, and if we come back probably 12 years back, Nico Pils showed in the registry that in 750 patients in whom the stent was implanted at the length of 17 millimeters, he showed that the higher post-PCI FFR, the lower the MACE rate at 6 months follow-up. It's interesting to note that FFR value above 0.95 was achieved in 36% of cases, and the value above 0.9 was achieved in more than 70% of cases in this study. So Dr. Johnson, in his meta-analysis, which was done more recently, showed that prognosis is related to FFR value after the procedure. So the term then comes that we shouldn't have the hyperemic residual pressure gradient within the stent, and this should be prerequisite for optimum stent deployment. And the result we should aim for would be the FFR value which is found almost in the normal coronary arteries without any resistance. I am showing here some data from the patients treated with some ultra-long stents, so-called. So probably they had diffuse coronary artery disease and they needed more than 50 millimeter stent implantation. So if you see the group below with the 50 millimeter stent they had at 4 years follow-up, the MACE rate was 2.5 times higher if you compare to the ones who needed the stent less than 20 millimeter implantation to fix the problem. Okay, and it's important to note that all these patients were done using IVUS imaging. So it was optimal PCI performed guided by IVUS imaging. We thought to look at the patients with long lesions, and we defined that the long lesion is the one who needs at least 30 millimeter stent implantation. And this was prospectively done, and we actually took all incomers to our center. We looked at the baseline FFR value when we placed the sensor just quite distally at the beginning of the distal segment, as you see here, which is shown in the LED. Then we implanted the stent to treat that long lesion, or 2 stents or 3 stents. Operators were encouraged to post-dilate to achieve a good angiographic result. And then we reassessed that stent implantation by FFR. We actually wanted to get as high as possible FFR value, and we were looking to get it above 0.95 in this population. Therefore, the stents were heavily post-dilated, and 3 spots we interrogated with FFR. Distal part of the treated artery, distal to the stent, just almost at the edge of the stent, and proximal to the stent. Therefore, we were able to see where the gradient is the highest. Is it within the stent or it's distal to the stent? All right, this is FFR gradient. It's not a pressure gradient. And then we repeated the same measurements 9 months later. Okay, so again 3 spots 9 months later. So 74 patients were included. We were able to do angiographic and functional assessment 9 months later. And you see that the clinical characteristics, they represent just typical all comers, and the mean age is 67 years old. Majority, more than 80% of them were with the free vessel disease, and a third of them presented with an acute coronary syndrome, and all of them had well-preserved ejection fraction. We subdivided the further on into 2 groups. So in the group so-called long, the stent length needed to cover the lesion was from 30 to 50 millimeter, and ultra long dash group, the stent length was more than 50 millimeter. So there are some QCA values here, and it's sorry for quite busy slides, but if we come here, so fractional flow reserve at the baseline was 0.61. Post PCI, it improved to 0.88, and as you could expect it at follow-up, it slightly decreased to 0.85. And in the ultra-long stent group, the FFR value, as could be expected after the PCI, was a little bit smaller than it in the long dash group. And please pay attention to the gradient within stent. So you have it 0.07 in the ultra-long stent group and 0.04 in the long dash group. And also, distal to the stent, you have residual gradient, all right, which is more pronounced in the longer stent group. Similar gradient appears at follow-up, and it's even increases, but not statistically significant increases noted. So this is the histogram. This is the distribution of the cases according to the FFR values. So on the right side, this is what we aimed for. Actually, this is what we aimed for, to have as many cases as we could with FFR values above 0.95. So if the lesion length needs to be treated with the stent length more than 50 millimeter, you cannot get, we were not able to get FFR result post-PCI above 0.95. And on the left side, this is the FFR below 0.8, so at least 10% of cases are remains in that range despite the treatment, and the rest are distributed between 0.8 and 0.9. At follow-up, you have probably about the same result. It's just smaller numbers with the result above 0.9. And at 9 months follow-up, if you look angiographically and you define, okay, this is restenosis if it's 50% or more, so you have restenosis rate 4.7%. And if you do the measurement by FFR in these long lesions, and you say, okay, this is functional restenosis, then you would say it's about 15%. And you have to keep in mind that we excluded the ones that after the PCI were after the PCI the FFR value was below 0.8. So these are 15%, the ones who declined from some FFR value which was above 0.8. So the cardiac death rate was about the same 2 years ago, and at 2 years follow-up or 12 months follow-up, and target vessel revascularization in our cohort was 8.1%. So we keep it short. In conclusion, I would like to again to say that if it's a long coronary stenosis above 50 millimeter, post-PCI FFR result above 0.95 was not achieved. And to have higher incidence of functional versus angiographic restenosis. But despite that fact, clinical outcome still is not bad at 2 years time. And maybe for the clinical practice, if it's LAD and to have long LAD stenosis, you probably shouldn't do FFR, otherwise you should consider for Lima after the PCI. Thank you.
So thank you again for a very nice talk. Any questions from the audience or the panel?
Congratulations, it's a very nice paper. Did you systematically look for drifts? And did you do a hyperemic pullback recording in all patients?
Yeah, you see, originally the thought was that we will not be concentrating very much on post-PCI result. We thought that if you place 2-3 long stents, then even mild neointimal proliferation at 9 months would give us some resistance within the stent. So we were not so precise with details on what we are doing during the PCI. So it shouldn't be a big drift, otherwise it would be noted. But if it's 0.01 or 2, it could happen.
Okay. And the other question that I would like to ask you is whether you did some statistical analysis, whether this post-PC FFR value was an independent predictor of MACE that you found during 2 years.
No, it wasn't. It wasn't.
It wasn't done, or it wasn't?
Yeah, it was done, and because it was negative,
independent.
we didn't report
the numbers are too low, I think, for that.
Has anyone systematically looked at IVUS measurements, looking at the relationship between post-PCI MLA and low post-PCI FFR? Is there any relationship?
What I'm aware of is a study done by Nico Pils in I think around 2000, which showed that what they did was placing the stent at low pressures, like 4 to 6 atmospheres, and then going up and see what's happening to the FFR. And I think even at quite low pressures, when most of the stents were expanded, the pressure gradient was almost gone. So this is why they concluded that post-PC FFR value is not a very sensitive tool to detect underexpansion of the stent. I think I can look it up in my laptop, this publication, but this is only one.
And I mean, in this case it was 80% of post-dilatation, so the stent was implanted at 14 atmospheres, and then post-dilated at 16 or 17 atmospheres. So there is no more space that you can do something within the stent, and you still do not have a good FFR result.
So for the people that measure post-PCI FFR, if you find a low value, what do you do out of interest?
Try to think as a physician. I mean, I think that you're going to try to optimize everything you can. I mean, in my view, I thought that, we have learned so much, especially from Nico Pell's data about the underexpansion of stent. But with the newer generation, I would say that for most cases, this is out of the equation. We do know, everybody knows about the high pressure, and we do know how to deploy stents. So I was thinking that the more, at this time, I'm more concerned about the impact about diffuseness of the disease, and what is the additional risk if you put a second stent. That's why there is kind of the conservative view from the Japanese when, when they are above the threshold, they stop. And to be honest, I mean, it's a pity that we missed the BVS at this time, because I think we do have huge respect for the mid-LAD. And if it would have been okay and we could put some BVS, and we do not jeopardize the future of the patient if he needs cabbage 5-10 years later. But now, I mean, we are stuck with the metallic cage, and probably we should stay on the safe side and be more conservative. But it may change in the future. So if I can ask, I mean, what people doing post-PCI FFR believe that we should do more registry data, try to identify the relationship between lower FFR value, or you think that we should now think about doing a randomized angio versus post-PCI FFR?
Excuse me? Well, actually I don't know. I don't know, but I mean, if you probably should measure them, but the value that you could expect, it would be different for the one with the short lesion, longer lesion, and very long lesion. It will not be the same value that you can achieve. Go ahead, please.
Yeah, we did some calculations on the sample size of a potential trial aimed at seeing the role of post-PCFR, and what we figured based on the FAME-1 and FAME-2 study that I just showed you was that more than 4,000 patients would probably be required to show any difference in outcome if you are basing your decision on post-PCFR. Of course, if the community is ready to do that, I'd be more than happy to contribute.
But I have a question, I'm sorry, just to add to the discussion. So how actionable is, how often the results you get with the post-PCI FFR is really actionable?
If you look at some data, there is a group in Arkansas which have been quite active recently. I mean, although sometimes I disagree with the data, but they still continue to claim that between 10 and 15% of the cases, they will change, they will do more, really on the PCI technique and stent deployment and using the imaging. So I think that's, we were going to learn more from the Rotterdam trial when they still use the imaging to see how often you can improve the result. At the end of the day, they will still have a significant number of patients with a low value that nobody knows what to do, but...
So is it doing more in the cath lab and technically, or this is something that we should probably think of medical therapies, intensifying medical therapies and optimizing and...
what I think is usually a missed opportunity is doing a hyperemic pullback recording at the end of a procedure to see where exactly the problem lies, whether it's a drift, because that may still be the case, especially in a complicated PCI with old-fashioned wires. It may still be the case that we are measuring something very low, when in reality we are having a good result. So it's easy to rule out. And secondly, yes, we have to check for whatever can be actionable. I mean, whether there's too much of a gradient across the long stents we've just placed, and it's easy to post-dilate. But in a number of cases, I think we will agree that it's the diffuse disease that we actually cannot treat just by placing many more stents.
It means that it's just more disease are there present there. And I showed you that slide with Honda, Dr. Honda, who did with IVUS guidance. You simply have more worse outcome if it's longer than 50 millimeter. And then there is AVIO trial where they used IVUS in order to optimize PCI technique, and they looked if there is any impact on the clinical outcome if you do with IVUS. And they compared with the angiography guidance, and what they achieved, it's just that the minimal luminal diameter is higher, but it does not translate to any clinical outcome. So I'm not sure that if you would redo the same using IVUS, you would get better numbers.
I would just, in my view at this stage, I would encourage people to do more report and publish their own experience, because I mean, we can be very enthusiastic doing post-PCI FFR, especially using the new wires. But sometimes, I mean, you get completely discouraged. I remember I did one instant restenosis for diagonal, and I was measuring afterwards, and I ended up finally on the LAD, and then I spent like 1 hour, and I thought it was done. So the mindset and the burden of doing more, I mean, it's something very difficult. So I think that just by having more people trying to understand, it's a very nice field, and I'm sure we will come up with something, but the burden is huge, in my view.
Yeah, so one thing, I mean, it seems that all the issues are unique to the LAD. So how often do you think you have undiagnosed myocardial bridges? And is that I mean, I'm just trying to think outside of the box. So how many times? Because sometimes we don't see the bridges, but sometimes, and then you stent it.
Bridges to stent in?
No, we don't. We don't stent bridges. So what I'm saying is I don't stent bridges, so I think I didn't communicate well. What I'm saying is that sometimes we have undiagnosed bridges with disease, and we don't see the bridge, and then how often, I mean, because the problem seems to be with the LAD. Is that a consideration, even to think about that?
To be honest, I don't know for sure the answer, but I say that, I don't think the bridge, which would become apparent after stenting the proximal, would impact, because at the end of the day, you would assume that the bridge has no impact on the FFR to begin with. So the problem is more really the diffusion of the disease that you don't anticipate, and then suddenly you get stuck, and then you say, okay, there is diffuse disease. What can I do?
Yeah. And then you place the stent, and then I will decrease the gradient, another stent, and then you see that you are at the distal artery.
There is a price to pay at the end of the day.
Yeah, this is why we have to take this into account, that we make more trauma, more metal, more risk of instant restenosis, or even thrombosis for that matter. So clinically, we need to prove that what we are doing is good for the patient. But in the meantime, I think registry is very nice to develop. So I would also encourage everybody to take these measurements and to check for their own results. And what I can remember is a case that I did for diagonal stenting, and it was very positive. It was an FFR of 0.33. I stented it and arrived at 0.68. And in the very end, I realized that I was missing the ostial left main, which was causing all the drift. So this is why I keep measuring post-PCFR every time when I can, because of this kind of complication or this kind of caveats.
Goran, you've got a point.
Stent placement, and if you get a low enough value, then you do a pullback. If you don't see any focal stenosis, then you're done. If you see a focal stenosis, then you consider putting in a stent at that part. Because we are participating in the Prospect 2 study, where we do nearest IVUS in all coronary arteries after the procedure. And we do run across these fairly tight lesions that we don't see angiographically.
It's the kind of protocol that everybody will fight around the table, oh, very nice, very nice. And then you start recruiting, and then after 1 month there is no patient in the trial because everybody gets discouraged. That's my feeling. I've been trying for 2 years to make it, but this is really the burden of many physicians. I mean, everybody gets excited around the table by the protocol, but then the next day in the lab, I mean, everybody wants to go, speed up the whole process, and it's tough. We have to do it, but I think that it's gonna take very enthusiastic people, and especially by introducing, when you think it's done, and then you do the final pullback, and then you realize you have a drift, and then you go back to square one, and then you repeat everything. So that's, I'm convinced.
Because if you don't have any focal stenosis, you're pretty much done. If you have a focal stenosis, it's something that you can treat, perhaps.
Yeah, this is what pullback meant for. Yeah. But you will have, it's not, as I mentioned at the beginning, in the one with the diffuse disease, you will have the gradient within the stent. It will be all along the stent length. If it's by FFI, it's 0.07. And then another one would come distal to the stent. Another 0.05 or 6. Yeah.
Any other questions?
So maybe it's time to conclude this second PCI workshop. I would say that I'm very grateful for the attendance. I hope that I learned, so I guess that everybody has learned, and I think that it's a tradition that we established like last year. I hope you enjoy it. I hope we can continue the tradition with the help of Volcano, Absence, Boston Scientific especially, that make this meeting possible. We continue to travel the world, so we'll try to continue to motivate people to do more physiology. At the end of the day, we are all convinced it benefits patients. So this evening it's free. You enjoy, and then you can regroup. And tomorrow we'll start AIM-RADIAL, as you know, meeting, and there will be the gala dinner at the Porsche Museum, which is probably one of the main reasons when I decided to do the meeting in Stuttgart last year. I'm biased, but so enjoy it. No, we didn't have the funding for the Mercedes one, so we had to cancel. So enjoy, have fun, and see you tomorrow.